Hey, I'm Jocelyn Compton. Welcome to the Musculoskeletal and Connective Tissue Lectures. Chapter is going to cover a wide range of topics pretty quickly. While there's some high-yield topics covered here, many are fact-based and don't require as much conceptual understanding as they do repetition. I'm going to attempt to provide as many memory aids as I can and pictures to make this easier, and also indicate specifically which facts are likely to be higher yield than others. The trick here is to be strategic about the facts, and not to drown in too much musculoskeletal minutiae. Let's kick things off with anatomy and physiology of the musculoskeletal system, and we'll come back to the anatomy of the skin later in the chapter when we switch gears to dermatologic diseases. As we go through the anatomy and physiology, we will also highlight some key pathologies that are highly testable anatomy questions. Let's start things off with the components of a solid knee exam. Keep this in mind not only for the boards, but also out there on the wards. Knee pain is an incredibly common complaint. Let's start by talking about the anatomy of the knee. So, what do you need to know? There are only a handful of key structures here. Let me orient you to this picture. This is an anterior view of the knee. Here's the femur, here's the patella, the tibia, and the fibula. The patellar tendon is cut away, so we can take a look at the ligaments inside the knee. The first two structures, and the most likely to be tested, are the cruciate ligaments. The anterior cruciate ligament and the posterior cruciate ligament, fondly referred to as the ACL and the PCL. Why are they called cruciate? Because cruciate means cross-shaped, which is exactly what they do, form a cross. Now, how can you remember which one is the ACL and which is the PCL? Easy. A and P refer to where they are attached on the tibia. So, you can tell in this picture that we're looking for what structure out front. That's right, the ACL, because it's attached anteriorly on the tibia. And which structure is tucked behind, crossing to the posterior tibial attachment? That's right, the PCL. How would you test these ligaments? Using the anterior and posterior drawer signs. In the anterior drawer sign, if the ACL is out, the tibia moves freely in what direction? Anteriorly. Conversely, in the posterior drawer sign, you're testing the PCL. Which direction will the tibia slide? Posteriorly. Remember this. ACL goes with a positive anterior drawer sign, an anterior translation of the tibia, and the PCL is just the opposite. Okay, let's play a game of which would you rather. So which would you rather? A torn ACL or a torn PCL? I guess for me, I'd rather have a torn PCL, and here's why. The PCL is actually rather floppy as it is, and rarely in normal range of motion does it get very taut. On the other hand, your ACL is critical in maintaining normal knee motion and the tibial articulation with the femur. So you could get by without a PCL, but it'd be a little bit tough to do without an ACL. Now, let's move on to the periphery of the knee on the lateral and medial sides. On the medial side, opposite the fibula, we have the medial collateral ligament, or the MCL. On the lateral side, we have the lateral collateral ligament. These ligaments prevent abnormal tibial abduction and adduction. So one way the boards will try to confuse you is to test your understanding of abduction versus adduction. Do you recall the difference? One way to remember is that abduction is like being abducted, or moved away from the midline. Adduction is just the opposite, moving toward the midline. So how can we test these ligaments? By stabilizing the knee and exerting either a medially directed varus force or a laterally directed valgus force. The abnormal passive adduction test is when you apply a lateral valgus force on the tibia. If the MCL were out, what would you expect? A hinging motion about the knee, right? And what direction is that abnormal hinging motion? That's right, in abduction. On the other side, an abnormal passive adduction test is when you apply a medial varus force on the tibia. What will happen if the LCL is out? That's right, hinging and adduction. Finally, let's talk about the meniscus, which is the piece of cartilage between the femur and the tibia. You've probably heard of a meniscus tear before. What is unusual about the medial meniscus? It's attached to the MCL. This makes it less mobile than the lateral meniscus. Always test the MCL and the medial meniscus when you examine a patient. How do we test the meniscus? With the McMurray test. We are going to rotate the tibia while flexing and extending the knee. Now, internal rotation is when you rotate the tibia so that the toes point to the midline. If the patient has pain and popping, then they have a lateral meniscus tear. Just the opposite, or external rotation, will give signs of a medial meniscus tear. Next, we will make a brief foray into orthopedics. While you may not see a lot of questions around this topic, there are a small spectrum of diseases, mostly traumatic and metabolic, that you do need to be aware of. I think this section can frustrate a lot of students at first because human anatomy in its totality is extraordinarily detailed, and there are, in theory, an almost infinite number of ways that a patient can sustain injuries. That being said, however, this is always tested on step 1. But there are really only a handful of common typical injuries that you really need to understand, which means that this is a subject that can be memorized just like any other. So don't worry, you can definitely do this. Take a look at this knee. If I told you this knee was a football player's, could you imagine how that happened? If this is what you're thinking, then you're absolutely right. So what's the unhappy triad? Imagine your favorite football player is running for the end zone. To stop him, the defending player dives through his legs, often from the side. The resulting hit to the lateral portion of the knee would cause 3 injuries. The first 2 are ligamentous, the MCL and the ACL. See how these components sustain stress from a lateral hit? The third is meniscal, to the lateral meniscus. I know I just told you that the MCL and the medial meniscus are attached, and the medial meniscus can be damaged too. It's just that the lateral meniscus is much more commonly injured in this particular scenario. I keep this all straight by remembering that an unhappy triad injury makes you lame. You can think of it this way: LA for lateral and ME for meniscus, or L for lateral meniscus, A for ACL, and the M is for MCL. A lateral knee injury in a contact sport is probably the most common way that this is presented in question stems. The next 2 common knee conditions are prepatellar bursitis and the Baker's cyst, which we will tackle together. Prepatellar bursitis is also known as housemaid's knee because it's usually caused by extensive kneeling, and the bursa over the patella gets inflamed and painful. This is a superficial anterior problem. A Baker's cyst, on the other hand, is a posterior problem. It's a popliteal fluid collection that usually results from chronic arthritis. Cyst is a misnomer because it's actually usually an open communication with the synovial sac. If the Baker's cyst gets large enough, can it obstruct important structures? It sure can. A Baker's cyst rarely can result in a DVT. Alright, so which would you rather, a Baker's cyst or a prepatellar bursitis? I think I'd go with prepatellar bursitis, since it doesn't have the dire but rare complication of a DVT. That being said, both conditions are benign. Let's have a flash quiz. If this ligament shown here were torn, what might you expect to find on physical exam? An anterior drawer sign, because that was the ACL.